So Professor Shelley has shown how she like to evaluate these patients. Yeah, as she's a physiotherapist, but I'm a urologist, so I'm certainly getting more into video dynamics or urodynamics as well. So that's my presentation over here. How, when, and why to proceed with this method of diagnosis. So again, my conflict of interest, and this is the goal of treatment on patients with neurological urinary tract dysfunction. And keeping these goals in mind, I would not name it all together because we have limited time, but keeping all in mind, we can accept when to repeat a video dynamic that I have made and when to even you receive, because I work in all the time with adults, so I receive from the infants hospitals the patients where they're grown up after 18 years old. So after the time I've received, I make a video dynamic, and so I go on with a clinical observation, and when I see a clinical experiment, I set a new video dynamic as well. So in video dynamic, it's a combination of urodynamic study with imaging, and you get functional as well by multi-channel urodynamics and anatomical findings. So this is exactly what we get, and we consider the optimal procedure for the dynamic investigation in patients suffering from neurogenic lower urinary tract dysfunction. In 2018, we have a lot of guidelines, recommendation, showing committees and review articles that help us to define where to, when, or how to perform a video dynamics. We're going to talk about these two one that I prefer, the European Urological Association, that can find as a combination of Philips instrumentry and pressure flow study with imaging. It is a gold standard for the European Association of Urology for urodynamic investigation in neurological disorders with a grade of recommendation A. And for the American, from the EUA and the SUFU guidelines, they have two statements about video dynamics. One that it says that when available, clinicians may perform fluoroscopy at the time of urodynamics or video urodynamics in patients with relevant neurological disease at risk of neurological disease and elevated post-void residual or urinary symptoms. And the statement 18, this has a grade recommendation C, and the 19 statement that may perform video dynamics in properly selected patients to localize the level of obstruction, and this not have a grade recommendation, but is an expert opinion. So we all know that making video dynamics in neurodegenerative patients is a challenging problem. We are almost treated with elderly patients with carrying multiple comorbidities, well, poor or no mobility at all, inability to communicate, impaired bladder sensations, or inability to express or understand their own needs or their own sensations as well. So it's a hard work to do. We start how to perform it, and the best thing is the position. We prefer to use an RC to perform this because we give us the liberty to get in different positions. Sometimes it's needed a chair like this when for neurological patients, and maybe consumable that you have to consider that a lot of patients will can present the autonomic dysreflexia. So this is a dangerous, life-threatening situation. So bladder pressure may be monitored during the procedure, and every unit that perform a video dynamic in these patients can have a protocol for that situation. So I prefer to oblique position in these patients as to see the you see the bladder neck. So I get the image of the leakage, and sometimes I get the images of the ureters as well. So I prefer oblique position if it's possible. I may say that sometimes move patients with these mobility problems is not so easy. and you have to do your best. And sometimes even if you start in supine position because you have to instrument the patient, then you move the position, of course, if you can, to the standing position to have a more physiological feeling and a more physiological evacuation. Although the evacuation of the bladder should be in the position that the patient is used to have it. So, and when you get to the standing position, you have to understand that also we have to use a drain pipe to obtain the liquid, and then a long pipe to the flow meter. So you have a time lapse between the incontinence and the marks of the incontinence in the uroflow meter. So, but you can get the images as well, so you can get at the time you get the first leakage. So it's important because you have images. In these patients, in neurological patients, you do have another problems. You need a proper rectal preparation, and neurological patients should have neurological bowel stool impactation as well. Other patients are in a bowel problem, but at the same time, you have to prepare the patients with suppositories or enemas, and you have to measure well the time between you have to perform the procedure and the time to prescribe the indications for the procedure, as to get a good pressure abdominal results. And a lot of patients have diminished anal tone, so this is another problem, because during the procedure you get the pressure of the abdominal pressure going down, and sometimes you get the balloon out of the rectum, so you get in the position that you get to start all over again, and with the patient, in this patient with a great motor disability, is something that is no easy to do. Sometimes patients have no anus at all, and you need to go to find another ways of measure abdominal pressure, and you can use in females you can use a vaginal tract, or maybe patients who are with intestinal diversion, you can go to transostoma, and you get the abdominal pressures really fine well. Here are the International Incontinence Guidelines of the ICS, and we can go through the filling rate. The filling rate should start at 10 milliliters per minute, and then going on further but always below 100 milliliters a minute, because we all know that up to 100 you will start to activate a neurological detrusor activity. So the less possible filling rate should be recommended. Also, we should use body warm solution. Also, the temperature of the room should be the most required possible. More dilution possible of contrast solution. And when you use electromyography, we have to establish that I use surface electromyography, but I do not always get the results that I want. I prefer to use needles, but in my country it's not so easy to perform electromyography with needles. We have to go with electrophysiology, and sometimes it's not possible. And with the time of X-ray, we have to get the patient the less possible exposure to radiation. When all is set up and the position is right and everything is going well and everything is established, you have another problem, and it's the communication with the patient. Sometimes the patient have the not possibility to talk because, for example, a stroke, and you have to communicate with signs, which is not a problem. You can ask the patient just to raise your hand when he feels the first desire to void, but in other times you have to the patient have no possibility to understand their own needs. So you have to trace on you have to trust on on your trace and on your images. So as you get in late now, you can see a few examples of video dynamics. This is a phase detrusor. This is a phasic detrusor overactivity. There are a lot of neurogenic detrusor overactivity. This is a phasing detrusor overactivity. With you see the climbs of every detrusor condition, but always restoring of the basal pressure initial. So this is useful to determine the detrusor overactivity Lippmann pressure, which is the same as detrusor Lippmann pressure, but it's a new term regarding the lowest pressure of the detrusor where urine liquid occur. So, and this is another kind of detrusor overactivity. This is sustained detrusor overactivity, where the detrusor contractilities never go to the resting pressure level, never go again. So this is different for alternative compliance. So this is a new term, and we consider as a high detrusor pressure overactivity in terms that the investigation could analyze that is affecting possible renal failure. And this is another threatening life situation, that is the detrusor dyssynergia. Here have the contraction, here have the sphincter overactivity at the same time of the detrusor overactivity. Here's the signal of the contracted sphincter, and you can see also the reflex of the two ureters. So how to follow up the patients is not always needed to perform video dynamics as well, like in children every year, but in adults maybe it's recommended to go with serum chemistry to evaluate kidney function, renal and bladder ultrasound, and abdominal radiograph, although there is not a recommended on routine imaging studies in those with the patients. So in conclusions, I think that video dynamics are immensely helpful in localization the site of obstruction when high pressure flow studies exist, should be done at baseline and might be incorporated into follow-up for individual cases, and is strongly considered in patients with impairment of renal function or structural change in the upper urinary tract, particularly in spinal cord injury patients. Thank you. Do you have any question? Yes, you can go to the microphone because being taped.
Hi, my name is Jerissa Upton, and
Welcome.
I manage, thank you very much. I'm a non-clinician, but I do manage an incontinence clinic. And so I have a question about urinary patients in particular, and perhaps you and Beth can both speak to this.
Okay.
So the urodynamics, I understand why we're doing it, but for patients with neurodegenerative disorders, I always wondered if it would be procedurally or ethically possible and then useful to use therapies like nerve stimulation for patients who have trouble communicating. I always just imagine that way you could actually test the response of the system itself and see the patient's response to that. I don't know if that's exactly how it works, but I am curious.
Okay.
Well, I will tell you that is not how it works. It would be nice if we could test them without their cognitive ability, but it just doesn't work that way. I will speak about the treatment component of electrical stimulation because that is useful, but it's not an assessment.
Okay.
I think that was the question.
Yes, because I know sometimes peripheral nerve evaluation, at least for fecal patients, can be used as kind of a test. But I didn't think the tibial nerve stimulation for urinary patients might function the same way.